Of food as medicine, and I really do appreciate your efforts over the years for bringing that message to the lay public. I'm going to go ahead and introduce the other two panel members and bring them up here to the front table. First, Dr. William Kay. Dr. Kay is the founder of Palm Beach Diabetes and Endocrine Specialists, and Ms. Melinda Dennis, who is a celiac dietitian and nutrition coordinator for the Celiac Center at Beth Israel Deaconess Medical Center in Boston, a Harvard-affiliated facility. Both are authors and leaders in their field on a national level, and I welcome both of you to the panel. I'm going to begin my presentation with an appeal to the physicians and other healthcare providers in our audience today to make good nutrition and nutritional counseling a part of your practice. The few slides I'm going to show are supposed to sort of impress upon you the magnitude of the benefit there is to using food as medicine. And it's also going to talk about my motivation for teaching myself about good nutrition and some of the common threads where healthy diet can help with such a broad range of chronic conditions, not just the ones that you typically associate diet with. Why did I decide back in 1998 to embrace food as medicine? Well, I guess the cliche is that medical schools do not teach doctors about nutrition or student doctors about nutrition. I certainly knew very little about it when I was in medical school. I was 1998. I was a third-year medical student. I think that there was all kinds of conflicting literature about how you lose weight and what diet is best. And I just thought, well, if nobody can agree, then it must not be that important. And if they're not teaching it to me in medical school, it must not be that important either. I did know a little bit about TPN, about intravenous nutrition. I think that since I was at UPenn, where TPN was invented, they did focus on that one small aspect. My wife, or at that time it was my soon-to-be wife, Ivy, was diagnosed with multiple sclerosis down at the University of Miami by Dr. William Shiramata. He was a professor of neurology down there, and I certainly spent some time looking up his credentials before I counseled my wife. She was given three options at the time. Back then, there were three disease-modifying medications available for MS. They were Avenix, Betaseron, and Copaxone. She was also given the opportunity to enter a research trial that Dr. Shiramata was part of for a medication called Antigren that ultimately became trademarked as a Tysabri and is still available. He also discussed with her the Swank diet. The Swank diet was developed by a neurologist who was practicing in Canada at the time. He did not have access to disease-modifying medications because they didn't exist at the time. So he was looking for other ways to control the progression of multiple sclerosis. He learned that there's geographic distributions to the disease. He spent some time in Norway, for example, on sabbatical, and learned that in the hills of Norway, there was a 7 times greater prevalence of MS than there was along the coast. Up in the hills, they predominantly source of protein was animal fats, butters, things of that nature. Down on the coast, it was, of course, Norwegian salmon. He thought that this was very significant, considering that Norwegians have a fairly similar genetic stock. He ultimately developed the Swank low-fat diet for MS, and this graphic is intended to show some of the results. This is a 35-year study. This graphic appears in the journal Nutrition back in 1991 and in his own books, and it shows how people who started out, some of these are his own patients, some are others from across Canada, with relatively low levels of disability, were placed on his Swank low-fat diet. The progression tended to be very slow. At 35 years, only 31% of the patients had suffered death or serious disability. In the other group that was eating on average twice as much hard fat, as it was the terminology he used, the progression was much worse, 80% death or serious disability. And this is a 35-year study, which is pretty unheard of in the medical literature having to do with nutrition. So I should say that in the group that was diagnosed that started the diet within 3 years of diagnosis, the progression to serious disability among those who are still alive was only 5%. And I think that that's pretty impressive, and I told my wife that let's give it a try. I mean, there's no need to commit to 70 years of injectable drugs at this time. In helping her, I learned quite a bit about nutrition. I spent a lot of time, as my first slide suggested, in the library. I think the Leonhardt diet study was probably one of the bigger news seminal publications back at that time. This is published in 1999, as you can see, right about the same time that I was first starting to learn about nutrition. It compares a prudent, healthy diet, which typically was a little bit of advice about eating less fat and less cholesterol, with a Mediterranean-type diet in persons who had already suffered a first myocardial infarct. There was a reduction in clinical endpoints of between 47 to 72% amongst the two groups. The endpoints included unstable angina, stroke, heart failure, additional myocardial infarction, death, and hospital admissions for chest-related pain. The magnitude of this benefit really impressed me. I mean, 47 to 72%. I mean, in this study, they compared the benefits of aspirin, which decreased the endpoints by 18 to 41%. And aspirin is one of our strongest allies in the fight against heart artery disease. So this pretty much convinced me that I was not being told all the truth about healthcare, and that really nutrition had to be at the forefront. I did notice also some similarity between the Mediterranean diet and the Swank diet, which helped me come to some additional conclusions. Where else does diet make a difference? Certainly, diet affects obesity. That seems pretty logical. In this graphic here, you can see that the amount of plant foods in one's diet as a percentage of total calories makes a big difference. You don't have to concentrate on counting calories or not eating this or not eating that. Let's just say you eat more plant-based foods. I mean, the vegans in the Seventh-day Adventist study had an average BMI of 23.6, and as you move towards the milk and egg eaters, the fish eaters, the quote semi-vegetarians and the non-vegetarians, you see a steady rise in body mass index from an average of 23.6 to 28.8. How big of a difference is that? Well, for a person who's 5 foot 6 inches tall, this is the difference between 146 pounds and 178 pounds. No complex dieting, no food limiting, just making a commitment to eat more plant foods. Other than for the effect on your BMI, how does this affect your real health? This graphic shows the increase in diabetes rates from persons with very low BMIs. And as we go up the scale, you can see the rate of diabetes increases for women 40-fold, for men 96-fold. For that relatively small change in the BMI associated with the plant food intake from 23.4 to 28.8, there's still a 4-fold increase in the risk of developing diabetes. So it does matter, considering how many other conditions are related to diabetes and how expensive diabetes care is. Other benefits, I certainly spent some time researching other conditions. This is only just a smattering of them. Rheumatoid arthritis, there's good studies showing long-term increased risk of anti-inflammatory omega-3 fats decreases the risk of developing rheumatoid arthritis about 50%. Rheumatoid arthritis is an inflammatory condition. In some ways, MS could be considered that as well, and there's really no surprise that similar strategies can help with both conditions. Asthma, just eating more fruits and vegetables decreases the risk of kids developing asthma by 46%, in the highest quartile versus the lowest. Stroke and cognitive impairment, a lot of dementia is related to vascular disease, so certainly approaches that would decrease the risk of heart artery disease are going to decrease the risk of developing dementia and stroke. Cancer, I wish there were more studies dealing with diet and cancer. I found a good case control study dealing with malignant melanoma showing that simple dietary measures can decrease the risk of developing melanoma, probably because it's an autoimmune and to some extent inflammation-related condition. Other cancers, not as many good studies. High red meat intake increases colon cancer risk. Breast and prostate and other hormone-mediated cancers, including colon cancer, are certainly related to weight, so they are indirectly related to a healthy diet. And this slide just shows the common thread. I mean, pretty much any condition that's related to inflammation or to malnutrition, and by that I mean inadequate nutrient supply, is going to be affected by healthy nutritional habits. Diet significantly affects weight, significantly affects your chance of developing diabetes. Inflammation-mediated conditions, including all vascular diseases, are highly affected by diet. Many autoimmune conditions are inflammation-mediated, including, obviously, rheumatoid arthritis, asthma, and MS. Food is valuable medicine here. We can work hand-in-hand with medication in most cases. In general, cancers have not yet been shown to be as sensitive to diet, but there are certainly relationships, and we need more research here. And I think that the bottom line is that we need to recognize that the percentage benefit associated with improving nutrition is greater than the percentage benefit associated with using commonly prescribed medications for many diseases. And it needs to be part of the counseling that we provide to our patients. It needs to be the future of medicine. Thank you. Thank you very much. And now Dr. William Kay will speak.